I'm finding out that what I'm going to talk about now as a theory or expectations that we have, the clinicians have, actually they are in the daily life, and there are companies that are actually developing that. The idea that we have is there are many breakthrough techniques now, many new technologies that are developing in the world and in medicine, and this is, sometimes it's scary. It's scary because when we see a patient, we don't know what's the maximum expectation that he has from us and what we can give him back as new technologies. And out of these are artificial intelligence and big data. Both of them are machine learning too. They are very connected between each other. So I'm not going to talk about what is the artificial intelligence, because everybody, the technicians here know a lot better than me. But I'll tell you the way that I talk to my colleagues about what is artificial intelligence, because it's something that it's not always that clear. But I tell them it's a capability of a machine to think very similar to humans, and to learn very similar to humans. It's like teaching a child. A child, when he's very small, you tell him, look, if you learn that plus that, you'll get this result. Maybe the first time he wouldn't understand it, but on the second time or third time, and once he's starting to experiment and seeing many things around him, he starts making his neurons start making connections and start developing the knowledge or the way of interacting with life. And that's the same thing with artificial intelligence. The actual medicine now is a science that we are doing inside a specific physical place. This thing is changing. But when we go to a hospital or a patient comes to a clinic, he has some part of a luck of meeting what professional. Because he comes with a condition, very specific condition, very specific to this human being. So actually, he doesn't know, this patient doesn't know if I've seen 4 cases of his case, like him, or I've seen 4,000. My experience or what I have learned during my career may affect the quality of the information, the quality of treatment that I'm going to get him. And I guess that's where the artificial intelligence gets into the game. So what do we expect? What do you expect the artificial intelligence to do for us? First of all, better diagnosis. The patients are not only a biological part. The patients have, well, the clinical history, what other conditions they have, what allergies they have, the family history, but it's not only that. They have a big part of uncontrolled information around them. For example, a big city with pollution, a COPD patient may be affected with higher pollution in his city. This is something that I don't seek when I am sitting at the consultation. That's information that may be very interesting for me to have. Not only that, the genome and the gene expression that he has, maybe it's important information for me. Nowadays, what we use, it's a linear innovation way of scores. What's that? For example, here we have behind we have the Framingham score for heart disease risk to 10 years. It's based on a population, and we're observing it. The other one is the CHAS-BASC. This is the risk of having a stroke. So first, the first professor, he said, okay, if we find out the patient with congestive heart disease or with hypertension and they have diabetes, they get a score, and based on the score, I'm going to treat them to prevent a stroke. The second doctor comes and says, okay, let's develop this stroke score. We're going to develop it, and we're going to say, observing the population, we're going to have with vascular disease or with the sex of the patient, we may get better scores. But in this case, we still have 2 patients, identical patients, as score, and one has a stroke and the other no. Why is that? Maybe it's because of the luck of this patient, or because we're leaving things, not clinical things, not biological things, outside this vision. Examples. This is evidence that is published. Okay, marriage may improve chances of surviving a heart attack. Okay, what does have the marital situation to do with a heart attack? Or the psychological language on Twitter? Okay, this is a very interesting study. They took the psychological language on Twitter in a specific county, and they compared it to the reported heart attack, the mortality of heart attack or heart disease. It's almost identical. What does it have to do with a heart attack and Twitter? Or the other. I don't ask my patients when they come inside the consultation, how far do they live from a highway? In this study, if you live less than 100 meters from a highway, you had 2.5 times more risk than to have an ischemia. These are information that if I have them, maybe they will change the way that I treat this patient. And here, the last example, weather. Okay, everybody says, if I have rheuma, I have arthritis, with bad weather, I may have more symptoms. Okay, and this study, it showed with the sunshine time, myocardial infarction, the sunshine duration, the wind velocity, the minimum air temperature, and based on that, and this is Sweden, they are starting to modify the way that the medical assistance could go from one place to the other, from one city or one region to the other. So I know that I may have more myocardial infarction in one zone because it's colder, or it's a windy day. These are information that actually we don't have on a daily basis. And that's where artificial intelligence could help us. The second thing is to harvest the data that we have. We have terabytes of information of everyone and each of one we are here. But just 5% of that we use it for medical uses. We can use a lot more of that. Information, as I said before, genomes, the now connected patients, now we have the wearables, they can give us a lot of information about these patients. What for? To canalize them, not only to make new investigations in a new way of searching for new diseases or searching for new patrols, but also to may have lower cost medical care. Because we will pass from not only prevention, we'll pass from prevention to prediction. And actually, machine learning and in artificial intelligence, it's proving itself a lot better than the normal scores that we have or the medical expertise. And as an example, the red line here, suspected coronary artery disease, the red line, I can't see that. The red line is machine learning. The blue line, it's scores that we are using in hospitals. So actually, it has a lot better prediction than humans or the normal linear scores. And inpatient mortality, too. And here it tells us with how much time before I was able to predict if a patient's going to get worse once he is in a hospital. We are talking about 2 different hospitals, and 24 hours before, I have it here. This is 24 hours before and 24 hours after. And this is what the hospital did, and this is what a machine learning system did it. The interesting thing about this article is not the article in C. It's who's signing it. It's Google. Because they are using a lot of information. They have access to a lot of information, and they are trying to use it. But the information that they have, it's not always the correct information, the medical correct information. So what they are doing? Well, they are going with Stanford. So they are trying to mix both the knowledge that they have about machine learning or artificial intelligence with medical knowledge. Why? To harvest this information, to harvest this data. The best people who have working on non-health algorithms could take them and use them for health systems. The third expectation that we have about artificial intelligence: use machines to reduce errors. There are many errors. That's something human. That's something that we have on a daily basis. Sometimes we know that we've done an error, and some others we don't know. And this is the accuracy. That's the problem of accuracy that we have. And at the same time, for machines that today, we want them to help us with efficiency. For example, as was before, in the lecture before, there was how to CT scans for mammographies. I'm very glad to know that it's already working. On echocardiography. In here, in this study, they were saying that it was better than a specialized echographer to find out with the automated echocardiographer. It's not FDA cleared yet, not CE marked yet, but for example, in retinopathy, diabetic retinopathy, now it's FDA cleared, soon it's gonna be CE marked. What that? But with one picture of the retina, a machine would be able to detect if you have a retinopathy a lot earlier than an ophthalmologist. And what to say about the Apple Watch? For the moment, it's not that accurate, but it's like a child learning. In some moment, it's gonna detect arterial fibrillation a lot better than a doctor. It needs time. Or other applications. By taking just a picture of your fingernails, you could estimate how much hemoglobin he has. And patients who have anemia, maybe just taking pictures of these fingernails, they can know if they are getting worse or they need to go to a hospital. This is on market. And now that's skin vision. I have no stocks in skin vision, but I'm in love with this application. This detects melanoma, skin cancer. It has 1.5 million people around the world using it. For $20 a year, just $20 a year, you can take pictures, and in this moment, they started, I guess, in 2016, and since then, now they say that they have a better quality diagnosis of melanoma than a dermatologist specialist in melanoma. Why? Every day, they have 1,500 images uploaded to their data bank. At the beginning, it was slow, but now it's going faster, 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 and it's learning a lot better than a doctor. It's going to have been seen more lesions, melanoma lesions, than any doctor around the world. And of course, personalized medicine. We expect that from our artificial intelligence. We expect that of the communication between engineers and doctors. It's the future, but it's now, because every one of us is different from all what we've talked now, all the information that we have, where we live, where we live, with who we get contacted, with all the digital phenotypes that we have. Well, we take it together and we help our patients to support their decisions. To support their decisions in a very personal way. And of course, to help us personalize, the genomics, it's pure AI. Why is cheap now? This is the cost for a genome, a whole sequence of genome. In 2001, it was $100,000. Now, now in 2017, it was 1,000. And nowadays, it's 300 euros. You can have a sequencing of your genes. It's something, it's your database of whatever you're going to have during your life. This information is going to be able to help the doctors, if they know where to look, have the doctors help you. Why is it that cheap now? Because of the machine learning, the artificial intelligence, that's letting us make it faster and more efficient. And this takes us to a very, very special preoccupation for my colleagues and for myself. Am I going to be obsolete in a few years? This article is very interesting because actually it was a discussion between two professors. One was doing like the attorney, and the other one was like fiscal, and there was one saying yes and the other no. And actually it's very interesting. The conclusions, well, I don't think we're going to be obsolete. And in this article, neither so. Why? Because actually they're going to give us the gift of time. In these moments with our patients, I can have 20, 30 patients a morning. Echographists can have 50 echographies during a whole day. I wouldn't like a doctor to be I wouldn't like to be the patient number 50 in a whole day. Why? Tiredness, effect of errors. But if I have a problem, I want all the time of my doctor. And that's what I would like to offer my patients. The gift of time. Once I have all the automated or possible automatization of routinary things, starting from writing down the electronic health records, now we can do, well, we pass 70% of our consultation writing on the computer, looking to the screen instead of looking at our patients. Why? We have to put it inside. We're going to use artificial intelligence, voice recognition, natural language processing to be able to put this data inside the electronic health record, and besides all the routinary things that are doing, well, reading a CT scan, a normal CT scan, or a normal mammography, and I'm going to use this time that I'm gaining to be able to be with the patients who really need me. Because the basic foundation of medicine is the medical-patient relationship. So I'm there for them, but when they need me. When they don't need me, a machine can do my job. Thank you.